Welcome back to Oral Pathology. In this video, we will discuss a variety of genetic disorders and how they may affect the oral cavity. But before we get started, let me give a little disclaimer. I do not expect you to become a geneticist here. But as a dental professional, it is important that you're aware of these disorders and that you're able to recognize their significance. We'll start with some syndromes that result from gross abnormalities, gross chromosomal abnormalities. There are 4 syndromes that we will cover under this section. The first one is going to be trisomy 21, and then we have trisomy 13, Turner syndrome, and Klinefelter syndrome. Let's start with trisomy 21, better known as Down syndrome. This is one that you're likely already pretty familiar with, so hopefully this part of the lecture will serve as a good review. In this picture here, you can see some of the features associated with this condition. Feel free to pause the video and screenshot this if you'd like to. In particular, we will see a slanting of the eyes, a shorter stature. Our patients with Down syndrome are known to have congenital heart defects. So you want to watch out for that on their medical history. In addition, they do carry a high incidence of gingival and periodontal diseases. Up to 90% of our patients with Down syndrome will have gingival or periodontal disease. Down syndrome is associated with a late maternal age. So women who are over the age of 35 have a much greater chance of having a child with Down syndrome. I used to work in a practice that contracted with the county to see all of the adult housed special needs clients. So we saw a lot of patients who had trisomy 21, and they really grew to become my absolute favorites. They were always so happy to be there, so grateful. They were very loving, very affectionate. We typically did see them every 3 months because of their high incidence of periodontal disease. But they were difficult to take radiographs on because they had very large tongues and malpositioned teeth. But sometimes you really do just have to do the best that you can. With trisomy 13, we're going to see abnormalities in various organs, and sadly 70% of these patients do not survive past the first 7 months of life. So trisomy 13, 70% do not survive past the first 7 months of life. These patients would have a characteristic facial clinical finding, which would include bilateral cleft lip and palate, microphthalmia or anophthalmia, which means small or missing eyes. Turner syndrome is a condition that affects only females, and this one results when one of the sex chromosomes is missing or partially missing. So Turner syndrome, females only. These patients will have a wide variety of medical and developmental problems. They're going to be short in stature. They'll have webbing of the neck, edema of the hands and feet. They have a low hairline on the nape of the neck, meaning on the back of the neck. They're going to have a broad chest with widely spaced breasts, abnormal aorta, sparse body hair. They will have infantile external genitalia and primary amenorrhea. So there's a whole host of issues with Turner syndrome patients. As opposed to Turner syndrome, in Klinefelter syndrome, only males are affected. However, this disorder is not going to be detected until puberty. These patients will have issues with infertility, and they have very small, poorly functioning testicles. So as a result, they're going to be taller than normal. They have wider hips. They have a female distribution of pubic hair. They may develop female breasts. They have intelligence levels which are lower than normal. And as I mentioned before, their testes are going to be smaller and harder. With these patients intraorally, the maxilla is slightly hypoplastic. So again, Turner syndrome is females, Klinefelter syndrome is males. The next four disorders we will cover are inherited disorders which affect the periodontium. That's going to include cyclic neutropenia, Papillon-Lefevre Syndrome, focal palmoplantar and gingival hyperkeratosis, and gingival fibromatosis. Cyclic neutropenia is actually a form of agranulocytosis. This condition is all about the neutrophils, or the lack of neutrophils. So as you remember, neutrophils are significant in the body's ability to defend against infectious disease. When our white blood cell count goes up, our body is fighting infection. So with cyclic neutropenia, the patient is going to experience a cyclic depletion of neutrophils, typically every 21 days for 2 to 3 days. So they're going to be immunocompromised significantly every month. Symptoms of cyclic neutropenia are similar to those of infection: fever, lethargy, cervical lymphadenopathy. They're going to have increased vulnerability to infection, oral ulcers, and these patients are known for progressive periodontal disease, so they're going to be susceptible to necrotizing ulcerative periodontitis. Treatment for these patients includes just supportive treatment, antibiotics to prevent secondary bacterial infections, and they do have medications that help stimulate neutrophil production. Early treatment of infections in these patients is important, but also good oral hygiene can help lower the risk of opportunistic oral infection. So if you have a patient with cyclic neutropenia, helping them understand the importance of phenomenal oral hygiene because they are so susceptible to those more serious periodontal infections. Papillon-Lefevre Syndrome is a rare disorder, and it is associated also with aggressive periodontitis. This disorder causes periodontitis so progressive that they will likely lose their teeth within 2 to 3 years after eruption. In addition to that, they're going to have hyperkeratosis of the palms, knuckles, and knees, and a hyperkeratosis and fissuring on the soles and heels. They also have hyperhidrosis, which means excessive sweating. The treatments for this condition involve retinol to help control the hyperkeratosis, bone transplantation to help them maintain their natural teeth has been an emerging treatment for them, but a lot of times these treatments are not very successful. The patients typically end up in dentures very early on. Focal palmoplantar and gingival hyperkeratosis involves a hyperkeratinization of the palms, soles, labial and lingual gingiva. This one is going to begin in childhood, and it starts with the fingers and the toes, and there is no treatment for this condition, so it's just a hyperkeratosis. Gingival fibromatosis is also known as idiopathic gingival hyperplasia. Gingival fibromatosis is also associated with hypertrichosis, which is excessive hair growth. It's also associated with epilepsy and cognitive disability. The gingival overgrowth seen in this condition can be either localized or generalized, but it can grow so excessively that it completely covers the teeth. So in that case, the teeth would have to be exposed surgically. Self-care for these patients is imperative to impede the overgrowth of the gingiva. And often it's still going to overgrow, but the better they can control the local irritant factors, the less likely it is to grow so severely that it would impede the teeth structures themselves. Now let's move on into disorders which affect the jaws and the face. We have multiple disorders in this section. The first one is going to be Cherubism, and then we have Cleidocranial Dysplasia, Gardner Syndrome, Mandibulofacial Dysostosis, Nevoid Basal Cell Carcinoma Syndrome, Osteogenesis Imperfecta, Marfan Syndrome, and cleft lip or palate. Cherubism usually appears in children under the age of 5, and it is a benign inherited condition of the maxilla and mandible. These patients will have symmetrically round, full faces with bilateral bone expansion. So they will have also sometimes intraoral swelling or growth of the bone. Their dentition may be affected with premature loss of primary teeth or missing and malformed permanent teeth. They will also likely have malocclusion. Another feature of cherubism is their ocular hypertelorism, or wide-set eyes. They are said to have cherub eyes which look up to the heavens. So I guess that's kind of how they got their name. Radiographically, we would see multiple well-defined multilocular radiolucencies. If you remember from our earlier lecture, multilocular radiolucencies appear as soap bubbles on X-ray. So cherubism is associated with a soap bubble appearance on X-ray. Now, while this condition is usually self-limiting, surgical intervention might be needed to improve function or just to improve aesthetics. Cleidocranial dysplasia is also called Cleidocranial Dysostosis, and this one is distinguishable by its effect on the collarbone. So this is a board alert. With these patients, the clavicles are going to be underdeveloped or missing, which allows them to bring their shoulders in very close together. They're going to have other craniofacial malformations, but in particular, the clavicles are a distinguishing feature of this disorder. They'll also have a large head. They may have bossing of the frontal, parietal, and occipital bones, which just means a pushing out or a growth out, and widely spaced eyes. They may have numerous supernumerary and impacted teeth, and cysts can develop in association with those impacted teeth. So it's time for our first submission question for Chapter 6. What bones are characteristically involved in cleidocranial dysostosis? Gardner syndrome is characterized by osteomas in various bones and intestinal polyposis, which unfortunately leads to a high rate of colorectal carcinomas beginning at age 30. Osteomas in the facial bones will obliterate the sinus cavities, which leads to facial asymmetry. These patients can have multiple odontomas in the jaw, as well as skin fibromas, epidermal cysts, and impacted permanent and supernumerary teeth. Unfortunately, many of these patients will also develop adenocarcinomas by the age of 40. Now, this one is a terrible disease. Here is another board alert. Mandibulofacial dysostosis is better known as Treacher-Collins syndrome, and it has a characteristic appearance of micrognathia, or a small jaw. So mandibulofacial dysostosis is better known as Treacher-Collins syndrome and is characteristic of its small jaw. This disorder involves spontaneous mutation, which causes anomalies of the first and second branchial arches. 30% of these patients will be born with a cleft palate. They can also have conducive hearing loss and low and deformed ears. They will have a high palate, malocclusion, widely separated teeth. Radiographically, we would see a downward sloping of the orbital space, aplastic or hypoplastic zygomatic processes, so malformed or missing zygomatic processes, obtuse mandibular angle, a flattened or aplastic condyle and coronoid process. So these patients usually undergo correction or reconstruction of the deformity through surgical and orthodontic means. The before and after pictures that we have here are pretty incredible. But Treacher-Collins syndrome has a very characteristic look. Nevoid basal cell carcinoma causes multiple basal cell skin cancers and jaw cysts in 90% of the people who have this condition. There are 5 main components to Nevoid basal cell carcinoma syndrome. Those 5 components are multiple skin nevi, which are typically basal cell carcinoma, odontogenic keratosis, bifid ribs or spinal abnormalities, palmar and plantar pitting, and calcifications. Treatment of this condition involves surgical removal of the carcinomas and the cysts. Osteogenesis imperfecta is also known as brittle bone disease, and we have another board alert. This is going to be the most common inherited bone disease, brittle bone disease or osteogenesis imperfecta. These patients are going to have fragile bones that break very easily. They also have loose ligaments due to defective collagen, and they have a characteristic blue tinge to the sclera of the eyes. They can also have hearing loss, and they may be prone to seizures. So they just have very brittle bones. Cleft lip and palate have multifactorial etiologies. This can also occur as a component of a larger number of syndromes. But cleft lip and palate and congenital lip pits are the most common. Cleft lip occurs at the 6 to 7 week mark in utero, and a cleft palate occurs at the 8-week mark in utero. It's caused from a disruption in the normal facial growth and development. Surgical treatment is almost always required to correct that. Now, I have a personal connection to this next disorder. My step-grandmother and her family were plagued with this terrible disease, and while she wasn't my blood relative, she was always my grandma to me. And sadly, she passed away from Marfan syndrome. But also she watched her father pass from this, her sister pass from this, and her son also all passed as a result of Marfan syndrome. This is an inherited disorder of the connective tissue that affects many organs and organ systems. Because the connective tissue does not form properly, the effects of this are widespread and usually end up eventually in dissection of the aorta, which causes rapid death. And sadly, that is how both my grandmother and her son passed. The aorta detached from the heart and they bled out almost instantaneously. These patients will have a high arched palate, severe malocclusion. They have a long, narrow face, and they just have a very characteristic look because their bodies are very long, their arms and legs are abnormally long, their fingers are abnormally long. But they may also have habitual dislocation or subluxation of the TMJ and mandibular prognathism. They're usually going to be, as I said, very tall with very lanky, long arms and legs. So once you see a person with Marfan, you will never forget their characteristic appearance. This next set of disorders features conditions which affect the oral mucosa. So first we have Peutz-Jegher syndrome, white sponge nevus, neurofibromatosis of von Recklinghausen, hereditary hemorrhagic telangiectasia, and multiple endocrine dysplasia. With Peutz-Jegher syndrome, we will see multiple melanotic macules throughout the lips and oral mucosa. This condition causes benign GI polyps as well, and a small percentage, about 3% of those intestinal polyps, may undergo malignant transformation. So Peutz-Jegher syndrome, lots and lots of melanotic macules and GI polyps. White sponge nevus is a rare disorder which may be congenital and causes deeply folded, corrugated white or gray lesions of the oral mucosa, especially on the buccal mucosa. And it can sometimes be seen on the lateral borders of the tongue. These lesions are usually bilateral and symmetrical and typically asymptomatic. Neurofibromatosis of von Recklinghausen is also known as Recklinghausen's disease, and it is a disorder in which the patient is lacking the tumor suppressor gene. So they end up with multiple neurofibromas, which may be discrete and superficial, or they can be deep and diffuse. They may have pigmented lesions as well and cafe au lait macules on the skin, or axillary freckling, which is also known as crow's sign. They can have also freckling on their iris, which is known as leash spots. Intraoral neurofibromas are seen in 25% of the cases, but excision is not always attempted since they typically have numerous and recurring lesions. Telangiectasia is a it's a condition characterized by tiny blood vessels which cause a thread-like pattern on the skin, and it looks similar to what we call spider veins. So these are enlarged capillary ends which can lead to increased likelihood of hemorrhage. So we'd be worried about our patients continuing to bleed after procedures. This is mostly a cosmetic condition, but it sometimes requires prophylactic antibiotics due to a link between this condition and oral bacteria-associated brain abscesses. Multiple endocrine neoplasia, MEN2B syndrome, is caused by a mutation in a gene called RET. The RET or RET gene provides instructions for producing a protein that is essential for the normal development of several kinds of nerve cells. So as a result of that mutation, the patients will encounter multiple mucosal neuromas and medullary carcinoma of the thyroid gland, which is present in 75% of cases. They can also have benign neoplasms around the adrenal glands. The earliest sign of this disease occurs when there are neuromas on the lips and tongue, which cause a thick, large, bumpy lip. So that's going to be the first earliest sign of disease. They may be tall in stature. They typically have wide set expression, wide eyes, and mandibular prognathism. Our last set of disorders is going to involve conditions which affect the teeth. So we have Amelogenesis imperfecta, that one should sound familiar, Dentinogenesis imperfecta, Hypohidrotic Ectodermal Dysplasia, and Ehlers-Danlos Syndrome. We first learned about Amelogenesis imperfecta in oral anatomy, so hopefully this should seem familiar to you. But there are different types of Amelogenesis imperfecta. The first type involves hypoplastic enamel, so the enamel did not develop into a normal thickness. The second type involves enamel which is developed to a normal thickness but is poorly calcified, so that's going to be type 2. Type 3 is going to be a hypomaturation of enamel. So the enamel is going to be softer than normal and it will have a snow-capped appearance. So that's going to be type 3. And then we have type 4, which is a mix of hypoplastic and hypomature enamel. This type of amelogenesis imperfecta is often associated with toroodontic teeth. So it's time for our second submission question for Chapter 6. What is the name of the cell which produces enamel. There are multiple types of Dentinogenesis Imperfecta. With this condition, we would not see pulp chambers or root canals, and the roots are going to be shorter and thinner. Dentinogenesis Imperfecta is associated with a broader condition of Osteogenesis Imperfecta. So unlike Amelogenesis Imperfecta, which just affects the enamel, Dentinogenesis Imperfecta is typically associated with Osteogenesis Imperfecta, which affects the bones throughout the body. Hypohidrotic ectodermal dysplasia is a condition in which there are hypoplastic or aplastic features of all of the ectodermally derived structures. So we're going to see it affect the hair, the nails, the skin, the teeth, the sebaceous glands, the sweat glands, the mucous membranes, all of those structures which are ectodermally derived. These patients unfortunately have a high mortality rate of 30%. They are typically missing multiple teeth. They will have a low, large set of ears, and they're going to have mid-face hypoplasia, thin hair, and shiny, smooth skin. Ehlers-Danlos Syndrome is the last of the syndromes that we're going to discuss in this video. Ehlers-Danlos Syndrome is a group of more than 10 different inherited disorders with various patterns of inheritance. This is going to involve a genetic defect in the collagen and connective tissue, and it's going to affect the skin and the joints and the blood vessels. So the common characteristics are going to be skin hyperelasticity, joint hypermobility. So Ehlers-Danlos Syndrome, these people have the ability to bend their joints in ways that you and I cannot. Their skin is going to be super stretchy, so they can pull it out way further out than we could. They're going to have muscle weakness, poor body control, but their mental development is completely normal. Dental pathology in this condition would include hypodontia of permanent teeth, delayed eruption, dentin dysplasia, and absence of the inferior border. Okay guys, that's going to be it for our lecture on genetics and oral pathology. If you have any questions, as always, feel free to reach out to me. Don't forget to like my video or submit a comment, and I will see you guys next time.